Hi, I'm Julia Resnick from the American Hospital Association. In September 2020, AHA partnered with the Advancement League to host a virtual event for emerging health leaders, where we discussed how to create a more equitable path forward for maternal health. In this video, you'll be hearing a conversation between Eugene DeClercq, Professor of Community Health Sciences at Boston University School of Public Health, and Christine Bell, Program Executive for Women and Children's Services at Providence Health and Services. They will be discussing how the data tells the story of maternal health disparities in America and what we can do to change them.
We have about 20 minutes and a lot of room to cover. So, Dr. DeClercq, thank you so much for being here. It's a pleasure to have you here. And I want you to go ahead and just maybe set the stage by sharing how and a little bit about why maternal morbidity and mortality has worsened over the years in this country.
This is essentially a manifestation of a system that's been full of holes for a while. Systems or lack of systems to try to address the problems of women's health have been around for a while. And there's so many gaps in care that gets combined with another trend that's been going on that I won't actually get into in this as much with the slides, but that we've been seeing, which is a growth in the overall death rates of women 25 to 34. If one was to look at those, we would see an increase that's actually bigger than this increase. This presents the rates over time. There's a couple things to note here. This is from the CDC's pregnancy-related mortality surveillance system. And I think it illustrates two key points. One, the often heard big increase in maternal mortality. And the line that's often used, a mother giving birth today is more likely to die in childbirth than her own mother did 30 years ago. And that's true. I think it's important to note the other thing that you can see from this, which is it's not increasing anymore. It's been pretty flat now for about a decade. Now it's flat at rates that are unconscionably high, but the rates have been relatively flat. Now I'm going to get into some of the reasons I think that might be the case. Here's how we compare to other countries. And one could do a comparison with all countries. If we do that, the U.S. is around 50th, but many of those countries aren't really comparable to the United States. They're much smaller. They don't have that many births. This looks at other industrialized countries with large numbers of births and hence more stable measures of maternal mortality. And what you see is the United States is decidedly last. Now, as Dr. Bell and I will get into, we're going to talk about disparities in a bit, and there are times when people would like to write this performance off as being a function of those disparities, sort of implying that it's because other countries are more homogeneous than the United States, that's the only reason the United States is doing more poorly. I hate to disabuse people of that comfortable somewhat notion, but if you limited the analysis to just white mothers in the United States, instead of being last, we'd be last. And I think there's two key points there. One is those disparities are real and they're profound, and it's important to discuss them and get into those. But at the same time, there are more endemic problems in our system that goes beyond just those racial disparities. And it's also good to note that in these other countries, they're not nearly as homogeneous as we might like to think of as a rationale for our own problems. If you want to look at it over time, this is the data over time. And what you see is for the United States, pretty flat, as I've noted, in the last decade and a half. At the same time, those same comparison countries have decreased their maternal mortality rates. Ironically, they've decreased it from a lower base. In other words, 2 decades ago, they were doing better than the United States. We've been flat or a slight increase. They've actually declined through that period of time significantly. We also talk about maternal morbidity. This is the latest data we have on severe maternal morbidity. And what you can see is, again, a notable increase over time. Now, it's a bit tricky because much of that increase is coming from transfusions, and for people who get into the measurement of severe morbidity, it's oftentimes presented in two ways, one with and one without transfusions being included. You see them all here. And even in the case of the other severe morbidity measures, there's been a substantial increase in the last decade. an even bigger increase in the case of transfusions, and a large overall increase in cases of severe morbidity. Then we get to the question of racial disparities. Kristen, do you have a question about racial disparities?
I'm glad you asked. I do, because I think you brought it up, but I think we want to dig a little bit deeper into the racial and ethnic disparities, which I think we're all really starting to put some energy and effort into understanding better. And I think what we'd love to hear, I think, is again, what's your thinking in terms of what the numbers tell us about the root causes of those disparities, and what's been the impact even as we've grappled with COVID-19 in the last several months? The disparities have really started to show themselves in a multitude of ways, and I think this audience would be really interested in hearing a little bit more about those racial disparities that you brought up earlier.
Well, since you asked, here are the disparities over time, and I think there's a couple points to note from this. What those figures represent is the black to white ratios in maternal mortality and in the case of infant mortality, and it goes back a century. And I think it's really notable that these aren't new, that we actually have the same racial disparity in the most recent data that we had in 1940. So this is not anything to be proud of, but it's not a new manifestation of anything. It's the long-term set of problems. Note the other line on this graph. That's the racial disparity in infant mortality, and it's terrible. A black infant is about up to about 2.5 times more likely to die in the first year than a white infant. But those figures are consistently lower than the cases of maternal mortality, and I don't think that's an accident. I think it's a function of the fact that we've set up a system that focuses on the health of infants, sometimes at the cost of health of mothers. And part of what we need to think about is how do we support both? That this isn't an either or. Now, one of the convenient explanations that gets used around this, again, part of my job is to just go around and disabuse people of all the easy notions of how they explain these things away. One of the arguments that's made is this isn't really about race. This is about social class, and race is just capturing social class differences. And I think this is the most powerful figure I use in my talks, because the red lines represent maternal pregnancy-related mortality ratios for black mothers and the blue for white mothers. And it's broken down by education. And what this illustrates is that the pregnancy-related mortality ratio for a black mother with a college education is 60% higher than the mortality ratio for a white mother with less than a high school education. What you can see there is for white mothers, the more educated, that it goes in the pattern you would expect. The greater the education, the lower the maternal mortality rate. And in the case of black mothers, pretty much stays level at extraordinarily high rates through this period of time. So that reminds us that this is more than just education. This is more than just social factors. That institutional racism is a piece of this. The way we cover women, if you look at the data, women who are of color are much more likely to be on Medicaid, and there's more limits on Medicaid coverage, both during the pregnancy and in the postpartum period, which we'll get to in a bit. These things aren't accidental. This is a function of a system that's geared is doing exactly what it was set up to do, regrettably.
Yeah, you bring up a really important point. I mean, that within hospitals and health systems for a very, very long time, we're in the unenviable position where we could get caught in our own sort of echo chamber of listening to ourselves and trying to make things better in the echo chamber of the hospital, but really having to understand the historical experience of Black mothers, the influences of that coverage that they have, the social determinants of care, that it's much broader than that, and we need to think broader, we need to learn more, and we need to partner in a different way than I think we have historically, because as you said, our explanations just are debunked here. And so it's time for us to sort of maybe think differently and act differently. And I think that this is a group that's going to, I hope, provide some insights into how we might act differently within hospitals and health systems. Which means,
for those of you who are participating, we older folk, and I'm not including Dr. Bell in this, but we older folk are counting on you young people to fix all this at some point. So we're looking towards that.
So it leads me to my next question, which I think is really one of the opportunities, again, that we have in this forum is to talk about the challenges facing us. Can you talk a little bit about where we're failing and what challenges maybe you see ahead of us? We've alluded to many of them around Medicaid coverage, but there are other challenges facing us, certainly, that I think would be important for this group to hear as we build upon this topic today.
The policy discussion at the moment is really focused on Medicaid, right? A bill is just gone through Congress around it doesn't actually extend Medicaid coverage. It just makes it easier for states that want to extend Medicaid coverage. But much of that discussion has been pertinent. We can certainly go into that more with if people are interested. I just want to note a couple other things. There's been cutbacks in insurance generally as well, for private insurance, that's limiting women in a lot of these instances. A third factor is if you look at research, particularly for women of color, they prefer to have providers who are like them, culturally, racially, ethnically, via language. And if you look at the distribution of providers, doctors, midwives, nurses, it's disproportionately different than the population that they're serving. Having said this, again, it gets a little trickier, and let me illustrate some of that with the next slide. This is the mortality rates in hospital, maternal mortality rates in hospitals, and that's that blue line at the top. And what you see is that rate is actually going down over time. And I think that's an important thing to keep in mind. Now, this doesn't mean, by the way, that where it says home, that these are functions of home births. That's not what we're dealing with. It simply means women are dying at home. And I think if you want to take one slide from this to rethink this, I have this, it's like a poster on my wall. This is the one to think about. So when CDC was looking at its pregnancy-related deaths, thankfully they started to reorganize their data to look at the timing of death. And I think once you understand this, you understand the challenge that we face. So what this illustrates is that if we look at the entire time period from the initiation of pregnancy to a year postpartum, which is the period we look at for pregnancy-related deaths, about a third, 31%, happened before birth. In the bottom pair, you see about 17% on the day of delivery and another 19% in the week after delivery. So around 35, 36% are happening right around the time of delivery. And then another almost third are happening between 7 days and a year after the birth. All of which suggests that the efforts that are underway right now to improve hospital care are critically important, but they're not enough. They're a starting point. They're not the ending point of this process. And so if we take a look as well at the differences we see, this is from another CDC study from maternal mortality review committees, that if we're talking about these different timings of death, we're talking about different causes of death in those periods, which suggests we need different kinds of interventions to address them. So in some cases, we're dealing with clearly clinically important conditions like hemorrhage. In other cases, we're dealing with things like mental health conditions that are not going to be resolved in the 3 days a woman's giving birth in a hospital. And so that calls on the need to improve social systems as well.
I think also, the fact that 40% of women don't go to their postpartum visit is a clear indication that we've got a design problem there. And so that's another area of opportunity to really listen to pregnant women and to understand their needs in that postpartum period, extending into a year, but to really understand what will drive them to participate in their care in maybe new and innovative ways that maybe we haven't captured that 40% in the past. So I think that's another huge opportunity. Well, this is extraordinarily helpful, I think, to have us all on the same page in terms of understanding the magnitude of the problem, how far it extends, what are the conditions we're looking at. Those are really important elements of understanding maternal morbidity and mortality. But I think for this group, also really important to think about what can we do? So I know we asked you an incredibly challenging question that I'm not sure I would have been able to narrow down to 3 immediate items that we can do to kind of impact this. But give us your top 3, and then we're going to lean on this group to give us a whole lot more that we can do.
Since you asked again, one's the obvious one: expanding Medicaid coverage out to a year postpartum. That's a given. For people who aren't familiar with the situation, in the states that most states have more generous eligibility requirements for Medicaid for a pregnant woman than they do otherwise. And so in some states that's extreme, in others it doesn't make much difference. The setting up perinatal quality collaboratives are fantastic. I'm on the perinatal quality collaborative for my state, as well as the maternal mortality review committee. Those are great things, but it doesn't end at the hospital. It has to reach out to the community. And then to me, the most important thing is this last one, which is this isn't about maternity care. This is about women's health. That we need to start valuing women's health as a given in itself. That's the important thing. So that if we do that, women will enter pregnancy in a healthier state and be supported all through that pregnancy and going forward. And I'm not a big fan of the terms preconception care and interconception care, because what they suggest is we only care because you might get pregnant. I think we need to reframe this as it's women's health, and women's health in and of itself is important and needs to be a focus of our attention. That bit on the bottom is the website that I've established with students, and you'll have access to these slides through the AHA group. But I have about, 500 more on maternal mortality, if people are interested, that basically the students and I just put together materials and give them away. So if they help you in your own work and your own presentations, feel free to take advantage of that.
No, they're absolutely helpful. And again, I'm a big advocate of also community partnerships and sharing. And I think that as this issue has gained national attention, I know in our community, Rotary clubs and parent groups and other community groups are asking for information. And this is a great place to help kind of pull some slides together and be able to share that within your community, because communities are interested in exactly what you said, which is making women's health a priority in their communities. So, Dr. DeClercq, I want to thank you so much for this. It's been very, very helpful, but thank you very much.